ETAP procedure yesterday, and today we go to a presentation about ETAP, the final frontier. Jorge, I'm happy to.
No? Well, I would like to thank the organizing committee, especially Dr. Saras and Dynamesh, for the kind invitation to be here with you today. Thank you. I have nothing to disclose. Well, the extraperitoneal space is that virtual space that extends from the peritoneum to the fascia, investing fascia of the muscles in the anterior, lateral, and posterior abdominal wall and the pelvic floor. Therefore, surrounding the peritoneal cavity. In the anterior and lateral, this small space in the anterior and lateral aspects is where the surgery takes place, and it's called the extraperitoneal space. Operating this space is not new. Bartel in 1969 started doing surgery in this space, mostly gynecologic and urologic procedures, and the main limitation was the space until the CO2 was developed and then the dissector balloons. And then all these techniques came to light. What are the general advantages? Why to work in the extraperitoneal space? Well, in general, because we decrease the risk and manipulation of bowel. There is less operative ileus, and there is less potential for adhesion formation, and this is so important. The first cause of intestinal obstruction is still are adhesions, so very important. And from the physiologic point of view, I don't think it has an importance nowadays. There is less adverse hemodynamic alterations than with the intraperitoneal approach. But there are specific advantages of working in the extraperitoneal space for hernia repair. And the most important of them is that it allows the application of the modern principles of abdominal wall reconstruction, well summarized in this article. And they include the primary closure of defects, restoration of linea alba, giant prosthetic reinforcement of the visceral sac, and the mesh placed in the ideal position, that is the sublay position, with minimal fixation and others advantages. And I want to really stop here for a while to say that the mesh has to come out of the intraperitoneal cavity. Why? Because there is extensive evidence, empirical evidence, observations, experimental models, even clinical studies that demonstrate that any mesh produces adhesion, no matter the code they use. That there are superior outcomes when the mesh is outside the cavity, and this study represents a good source of that information. And more recently, we have an article that demonstrated that there is actual reduction of intestinal obstruction. And I want to stop a minute here to make relevance of the Lorne article. This is a 5-year follow-up article that demonstrated that no matter which mesh they use, coated mesh, the use of intraperitoneal mesh produces more intestinal obstruction. Moreover, when the intestinal obstruction arises, it needs surgery more often than when there is no mesh in the intraperitoneal cavity. So that is not the point. The point is, in order to put the mesh outside the semilunar cavity, the risk should be less than the advantages. And that is the message. So, in summary, it's much better to do an IPON, a well-done IPON, than a very bad doing ETAP or Milos or whatever. And, well, how we access this space? There are many ways to access the space. The classical one is the Reeves Topa, but there is a hybrid approach, a very interesting approach, that is the Milos approach, and there is the totally endoscopic approach to the extraperitoneal, and you can have it transabdominal, and then you have the TAP, the TARUP, TARN, or totally extraperitoneal, and you have the TEP and ETEP. To summarize, ETEP is a minimally invasive, totally extraperitoneal access remote to the hernia site that allows the creation of a large extraperitoneal space with flexible pore placement, expandable space by division of the natural limits of the space, or boundaries. But people tend to equal ETEP with retromuscular, and it's not. Retromuscular, you can use it in ETEP, and those lines are blue lines, represent all the places where you can access the space extraperitoneally. The red spot represents the TEP approach. But you can access the space, as we saw this morning, extraperitoneally directly from above, from below, and from lateral to the semilunar lines, as we did at the beginning of our experience. Before describing the crossover, we were repairing L4 lumbar hernias, directly extraperitoneal, not retroperitoneal, directly extraperitoneal, from lateral to the semilunar line, specifically for L4 hernias. This is the summary, so we can access the retro-rectus or the preperitoneal spaces with this technique. And this is a representation. This represents the more classical retromuscular axis, then the preperitoneal or prefascial axis, and then you have the Carolina crossover, in which you can access one side, retromuscular, and then you can navigate preperitoneal to the other side. So a lot of flexibility to do things. And this is a very good example, of course, coming from the robotics that allows to pinpoint the difference between the preperitoneal and pretraversalis. But Miguel already did that for us. And the advantages of the extraperitoneal space understanding was enriched by Dr. Miguel Garcia, who really taught us how to navigate in the upper abdomen beyond the costal margin into the diaphragm safely. And this is the classical approach, and these are the problems, and this is what he suggested that should be the way we navigate into that space. That is, dividing the posterior rectus sheath at least 6 centimeters below the xiphoid, and then go preperitoneal all the way behind the fatty tissue of the xiphoid and sternum. That's the safest way to do it. Those are the advantages. Also, he advised on the presence of nerve, intercostal nerves, and the neurovascular bundles that, as I mentioned, they come very medial and very thin in the upper abdomen, and we have to be careful not to lesion them. That has consequences. And these are the intercostal nerves, also coming to midline. There are other advantages. I'm going to go fast on this so we can be on time. The flexible pore setup is one of the most important, and I'm going to show you the most often resort to. The first one is the classical laparoscopic approach with 4 ports. The fourth one, they use it as a vantage point and a suturing port. This is used for laparoscopic surgeons all over. The next one, with 3 lateral ports medial to the semilunar lines, are the robotic approach. This is the most preferred for the robotics, and they can repair hernias in any place. And sometimes they have to do double docking according to the case. The next one is the less popular. It was first an incision to create the extraperitoneal space, and then 3 trocars in the inferior abdomen. This was advised for subxiphoid hernias, M1 hernias. The next one is the one I used very, very early after the introduction of ETEP, 3 trocars medial to the semilunar line and directly going extraperitoneal for repair of L4 hernias and also to perform triple neurectomies in the case we need it. More recently, there have been these descriptions of ETEP access from the inferior abdomen, and you can do the inferior abdomen retromuscular, but not at the beginning because there is no posterior fascia in the inferior abdomen, but then they continue retromuscular, and you have at least 2 examples. Yuri Muskin in Israel do it in this way, and another Valencia surgeon from Colombia do it as well, and Hector Valenzuela do it pre-peritoneal with these 3 trocars. And then you have our preferred approach, the precostal one, which I already discussed with you, and is based in this anatomical fact that the rectus abdominal compartment goes above the costal margin to insert in the 3rd and 5th costal margin. So you can access the space well above the costal margin with advantages. Some people ask me, well, what about the costal margin? You have to pivot over the costal margin. That should be painful. But as soon as you insufflate the space floats over the costal margin. There is no relation with the costal margin. So that's not a problem. And the advantages are here. We optimize the space, allow proper marking of the semilunar line that allows to place the ports in a better way, the lateral ports, provides the vantage point. That's why we don't need a 4th trocar, and provides an excellent suturing port, as I hope you saw yesterday. Other advantages, it permits the repair of minimal invasive repair of inguinal hernias, and it has advantages for TAP and TEP. I'm going to resume them. Over TAP, minimizes trocar side hernia. There is 13 times more trocar side hernias with TAP than with TEP or ETEP. Over the traditional TEP, well, first of all, the conversion rate is much less because it is not compromised by accidentally created pneumoperitoneum, but also paves the way to the ETEP ventral hernia repairs. We, as a matter of fact, did demonstrate that it was possible to do a robotic ETEP in a porcine model back in 2015. You can see we have a bilateral dissection of the extraperitoneal space and placement of meshes. We still have a lot of porks and pigs, but we don't have the robot yet. It allows for the repair of ventral hernias in all locations and the simultaneous repair of ventral and inguinal hernias, which we have done often in the same plane. Allows for example, in this case, we have a midline and a lateral hernia. We can access the extraperitoneal space from the opposite side. So ETEP rib stoppa, crossover, and then a unilateral TAR. So you have one plane to repair all these hernias. Also, it allows the more limited dissection for umbilical hernias, with or without inguinal hernias. These, for example, are the 2 authors I already referred to, in which you simply draw the area you want to address, and with 3 trocars, you can repair the hernia. But if the patient has an umbilical hernia that requires mesh and bilateral hernias, for example, you draw the area where the mesh should be for the umbilicus, then put the trocars ETEP accordingly. You create the space in the pelvis, and then you add a trocar suprapubic, and looking upward, you repair the hernia. And then, if I can move this, I don't know, can you play this video? You can simply place an individual meshes, a ProGrip, in this case in the umbilical, and then the preform in the inguinal region. So you have an access of those hernias in the same plane, minimal invasive, not extensive dissection. it allows a hybrid strategy. When to use it? Well, when you have skin dystrophy, anyway you have to resect it. You have a mesh with bowel involved, and you need to remove the mesh. You use a hybrid approach. Oh, simply early in your experience, if you need to close and you don't want to do the difficult upside down, you can simply make a small opening where the hernia is extended up and down and close the fascia in this way. And the most important advantage over all extraperitoneal approaches is that has been extensively evaluated in the literature. This was the first article that came to light. It's a multinational, multicentric article, and from that there have been a lot of them. Almost all meta-analyses conclude that comparing it with the IPOM Plus, it was less painful with faster recovery, shorter hospital stay. This is a recent investigation on the PubMed. By putting ETEP hernia, you can see how it has grown year by year, the number of publications. But as all in life, it has also disadvantages. The main disadvantages is that it has a steep learning curve that requires, I say, focal training that ideally should include cadaver lab and a mentor. The orientation is difficult. Early pneumoperitoneum may compromise the space. It still is not for everybody. If the patient has limited physiological reserve, or we have complex hernias or infected or fistulas, this is not the procedure to do. And it has inherent complications, hematomas, seromas, and the most important of them, internal hernias. Sometimes linea alba hernia, but those are rare. Here is the most classical complication of this technique is internal hernia that result from a blowout of the posterior closure. That's why you don't need to close the posterior rictus sheath. You don't need it, and it doesn't add anything good for the patient and put the patient in danger of this complication. By the way, ribs topa, or ribs in the original description, I have to look for the original article in France, they didn't close the posterior rictus sheath. They simply closed the peritoneum in most of the patients. And he had the same feeling, even he was doing open surgery, that closing could be more problem than advantage. Other complication, linea alba, this means the person who is performing the procedure had no idea of anatomy, because instead of crossing over, they open the anterior fascia and they confuse this fatty tissue with the falciform, and they continue that way. That creates a hernia that is difficult to repair. All these complications are well summarized in this article that you can resort to. It describes all the complications, how to prevent them. And finally, it may be, I already talked about this, it may not be cosmetically appealing for small ventral hernias in lean individual, especially sportish individual. It's not probably the best option. This is a good compilation of everything you can look for ETEP. I have to say I got no royalties for it, so no problem. This is a recent article in which you can look at all the evolving techniques related to ETEP. And wait for this. This is going to be a really exciting program. It's like guidelines on steroids. It's a self-assessment program that is made by expert, peer review, based on the best available evidence that summarizes all the knowledge in all aspects of hernia surgery. But the advantage is you can compare your results with anyone in your region or country or other continents. It's updatable. It has a clue word, so if you are going to go for a procedure, Just put the word and it will give you all the questions related to that. And is with the artificial intelligence that we are currently feeding that can resolve the doubts you have about a wrong question, for example. Well, I hope this summarizes why the extraperitoneal space is the final frontier of hernia surgery. Thank you so much.
Yeah, thank you for this fantastic overview of ETAP with all the aspects. Question?
Thank you. Thank you for your ETAP approach. I have some practical questions. Sometimes we perform ETAP for incisional hernia and peritoneum is very thin. And you think about I suture this peritoneum or use omentum. Sometimes I can use omentum. What do you think about if I have small perforation and I see that if I start suturing, I do more trauma for peritoneum. What do you think about if I can use some hemostatic mesh like Surgicel between peritoneum and mesh? Thank you.
Almost all peritoneal rents, if you do the procedure properly, can be closed. Simply don't follow a line. Just follow the direction which has less tension to do it. Decrease the pressure. Use a proper suturing like Vicryl Trior or Bilog Trior absorbable. But there are cases in which the rent is difficult to close. So you have many options. One of them is to put the omentum and suture the omentum to the border of the defect. In that way, you created a plane to isolate the mesh from the abdominal content. Or you can place a resorbable mesh or what you suggested, a hemostatic there. Or you can do a partial TAR, bottom-up partial TAR. It doesn't destroy the abdominal cavity and allows you to close those rents. So many options there. As you advance in your experience, you will notice that you will not need that almost never, because since you are starting dissecting, you are thinking about how to save peritoneum.
Thank you for this very nice presentation, and thank you for giving us the ETAP procedure, Jorge. One question, can you tell us something about mesh placement, mesh size, and mesh-related nerve problems? How far to the side you put the mesh, for example?
Yeah. First of all, thank you for the title of Father of ETAP, but I have to say, nothing in surgery is single-handedly done, my friend. It's with the help of so many people that preceded us and people that are improving the method. So it's a joint effort, never is an individual effort. And on top of that, if you are the father of something, what your kids do is your responsibility. So I don't want that. So, answering your question, well, the mesh we use is a large porous midway mesh. I prefer that one that adapts to the contours of the space without wrinkles and folds. And the one we use, really, I have to say, not because I don't want to go back walking to my country, but because it's real, it works very well. And now about the size, you have to size the space. You have to size it with a sterile ruler, as we did. You have to stand, we know that at least 5 centimeters in all directions beyond the defect. But in general, those patients have diastasis, you close the midline, so you have to cover the space. Measure the space, cover it, place it, unroll it, and you don't need fixation, almost never, I would say. Because as soon as you evacuate the CO2, the mesh is going to be fixed there. I don't know if that.
Yeah, thank you. You try to avoid the nerve contact with the mesh. How do you do that?
The nerve? The nerves. Oh, well, you don't go beyond the lateral nerves. If you need to do that, that's the TAR option or the peritoneal. You can extend it. if you have a case in which, for example, the patient have a very reduced width in the rictus muscle, very reduced, but the defect is borderline, 4 or 5 centimeters. So you need to extend the mesh. You don't need it. You don't need a TAR to close the defect because you don't need. There is no tension there. You can extend unilaterally pre-peritoneal. So you have the advantage. You can extend the mesh without doing a component separation. That's an option there.
Thank you.
Welcome. I think. Okay. Well,
Thank you.
thank you. It's my distinct pleasure to invite Dr. Birolini to talk about